Hey guys, Michael Foley, the Ceramic Implant Guy, here from day 2 of the ZERAMEX Corporate Forum in beautiful Zurich, Switzerland. We just had the honor of listening to Dr. Joseph Choukroun, who is most widely known and famous for his invention of PRF and his contribution to the world of PRF. But today, he gave a lecture that's new on how immunity controls bone formation as well as regulates bone resorption, and why peri-implantitis is actually an immune disease. So this was a really great presentation. It's on osteoimmunology and oxidative stress. So he gave us the opportunity to share the slides and the presentation with all of our fans. So without further ado, I'm going to spin out, give some sort of animation, show you one more time the beautiful view of Zurich, and enjoy the lecture from Dr. Choukroun.
Osteoimmunology and oxidative stress. I would like to share with you my 55 years of experience in medicine. As I'm not a dentist, all pictures of this presentation are not my cases, obviously. They are coming from my friends. We are facing failures and bone loss during osseointegration, after osseointegration, and after bone graft. From the literature, we don't have a clear answer. And then we can ask the question, bone loss, is it a fatality? During 400 years, we were following osteology science. But in 2000, Aaron and Choi came to introduce the osteoimmunology, which is a paradigm shift in bone science. What is osteoimmunology? We have two systems, immune and bone. Immune system influence the bone system at the early stage of angiogenesis. It's a key regulator in wound healing. Immune system is a key factor in bone homeostasis. Immune system controls the bone formation and regulates the bone resorption. The bone system influences the immune cell's function. And then we consider that we have only one system, the osteoimmune system. Recovery and osseointegration start by inflammation, which is an immune reaction triggered by inflammatory cytokines. And we know that these cytokines are mostly angiogenic. What is the immune system? We have cells, the white cells, all the white cells, and the hematopoietic stem cells. We have proteins, interleukins, antibodies, TNF. And we have the immune reaction, which is the inflammation. The first information that we need to remind all the time is that inflammation must be brief, should last maximum of 5 days. Yes, during the first 5 days, the inflammation is always beneficial, and we name it positive inflammation. However, if this inflammation persists after the 5th day, the effect is inverse and the inflammation becomes harmful. And we name it negative inflammation. Why long-term inflammation is harmful? Because it increases the production of free radicals, which are oxidant, unstable and toxic. And then, if we want to fight against inflammation, we need to use antioxidant, which will neutralize the oxidant. But it increases the production of rancor, inducing differentiation of macrophages in osteoclast, leading to a continuous bone resorption. And this is why we need to have a full balance between oxidant and antioxidant. However, sometimes we produce too much oxidant or we don't produce enough antioxidant. And we name this negative balance oxidative stress. Oxidative stress leads to major cells issue. DNA and cells membrane are damaged, leading to a delayed wound healing and inducing higher rate of failure and complication. Oxidative stress leads to dysfunction of immune cells, inducing a deficient immunity with inhibition of osteoblast and osteoclast activation. And then we will meet a lack of bone formation. Oxidative stress induces bone loss because of the increase of oxidant in osteoblasts. And then when you have too much oxidant, we will meet a bone remodeling failure. The bone does not resorb as a melting ice cream. It resorbs because it doesn't remodel. We can take a simple example of this mechanism. When we do an extraction, we meet a lack of mechanical activity, and then the bone becomes inflammatory with an excess of oxidant production. Then we have a bone oxidation with a phase of remodeling, and this is how the ridge resolves. We know that people, they are meeting more complication and failures. Simply, it's because they are in oxidative stress. Diabetes is a chronic inflammatory disease. Hypoglycemia induces oxidative stress, and diabetics are deficient in vitamin D. What is the issue with smokers? The issue is the smoke. The smoke breaks down the antioxidant in the gut. And the smokers are also deficient in vitamin D. So any kind of bad outcome, failure, complication, infection, resorption, the answer is very simple. It's because we have too much oxidant related to a chronic or intense inflammation. Inflammation induces oxidative stress, leading to immune deficiency. And then it's logic to meet an infection, always after the 5th day, when the inflammation becomes negative. Logic to meet resorption. Logic to meet fibrointegration, because inflammation leads to fibrosis. Long-term inflammation means osseointegration failure and fibrosis. What are the origin of oxidative stress? We have not enough antioxidants and too much oxidant. We will analyze each topic. First, we need to assess the level of oxidative stress in pre-op. And we have 2 blood markers, LDL cholesterol and the vitamin D. I published this paper 10 years ago with very famous opinion leaders in order to inform the dentists that they need to take care about the cholesterol and the vitamin D. HDL is a good cholesterol because it's an antioxidant. LDL is the bad cholesterol because it's an oxidant, inducing osteoblast oxidation. And then if the LDL is above 1.4 gram, osseointegration will be delayed. It will be impossible to meet any osseointegration if the LDL is above 1.8 gram per liter. When we have a high cholesterol, we meet osteoblast oxidation and the bone is replaced by fat. And the bone turns yellowish color. Brandmark, almost 40 years ago, was teaching his students with this sentence: when I see a yellow bone, I cancel the procedure. Now we understand that this patient, they were with a high LDL cholesterol. Vitamin D is moving to the blood after sun exposure or after taking in diet, and then we produce an active hormone. This hormone has two pathways: endocrine activity, which is the calcium metabolism, and paracrine activity, inducing anti-inflammation and mostly antioxidant production. Today, we consider the vitamin D as an immune stimulator. Recently, this paper showed that below 20 nanogram, vitamin D deficiency has a causative role in the systemic inflammation. When we lose the bone, it's because of the LDL or a low vitamin D. Same, high LDL, very low vitamin D. We understand that we have too much oxidant, leading to a remodeling failure around the implant, and this is how occurs the bone loss. Then we can explain most of complication. Allergy to penicillin. We know that we have an increased risk of infection, a higher rate of failures in implantology, and allergic when they replace amoxicillin by clindamycin, they are meeting much more failures. We can explain why. First, allergy is a dysfunction of immune system. T lymphocytes are the responsible releasing a lot of inflammatory cytokines, inducing an excess of oxidant production. But the allergic are deficient in vitamin D. They can't produce enough antioxidant. And then the explanation is very simple. They are in oxidative stress, and this is why they are meeting more infection and failures. Sometimes after bone augmentation, we meet resorption or fibrosis. Why? When we do augmentation, if the soft tissue is thin, then the bacteria, they penetrate and spread to the periodontium, inducing a chronic inflammation and a long-term release of inflammatory cytokines, leading to fibrosis or resorption. And then when we place a collagen membrane, what is the exact function? The collagen membrane should be considered today as an immune barrier, blocking the inflammatory cytokines coming from the soft tissue. When we do an augmentation, this kind is with an autologous bone, and we know that this is the gold standard. However, if the gum is inflammatory, it will induce resorption, even if it's a cortical bone. We have the foreign body reaction when we place a biomaterial, and this foreign body reaction depends on type of biomaterial. The most compatible is the human material, but close to the human, we have the porcine. With these two materials, there is no inflammation, no oxidation, and in histology, we don't have any giant cell. So far, we have the synthetic and the bovine, which are very inflammatory, low compatibility, inducing a long-term inflammation. And this long-term inflammation will induce bone oxidation, leading to connective tissue growth, fibrosis, and encapsulation. There is another source of inflammation, the biomaterial surface condition. It depends on the clinic condition. This is not well cleaned, very inflammatory, but a lot of debris inducing more inflammation. Look at the most known bovine material. We don't see exactly the surface of the bone. We have today material for bone graft from porcine, which are much better cleaned not perfectly, but the cleaning is much better. When we will use a highly compatible material, we will induce a positive inflammation, means low level and short term. We will meet oxidation after long-term ischemia. What does it mean? Mamoto published this paper in 2009. When we apply pressure or tension on a tissue, this tissue will lose its vascularity. And then we can take an example about the blood ulcers. Why the patient is meeting blood ulcers? Because he applies a constant pressure on the skin following a mandatory necrosis. When we have a tension or pressure, we will induce ischemia, oxidation. The result will be the bone loss. Soft tissue oxidative stress by unreasonable tension. Tension induces ischemia and oxidation, then bone loss. When we lose the bone, it's because maybe there is no vestibule. And then this chronic tension will induce daily bone loss. We have also the bone oxidation by unreasonable pressure. Means the implant is placed with an inadapted torque. We know from the science, from the Hooke's law, that the material reacts to pressure according to its density. When the material is soft, the stress is very low. When the material is strong, the stress is high. And then if we move to the bone, when the bone is cancellous, means flexible, there is no stress. If the implant is placed in cortical, this bone is rigid and we will meet a very high stress. When we place the implant, the most critical zone is the cortical zone. And then this zone has no plasticity, poor blood supply, and then we can explain the marginal bone loss. Resorption always takes place in cortical bone. Look at this mandible. One implant is cylindric, means doesn't apply too much stress. The implant which are tapered will apply a very high pressure at the crestal zone. And this is how we can see a bone resorption. If the cortical is sick, we will meet cratering, because cortical bone does not, never accept any pressure. This is an example of a cratering in sick cortical. We can see then after 10 years of implant placement in cancellous bone, the full stability is there. When we place implant in sick cortical, in only 1 year, we will see the disaster. So when we want to place an implant, we need to assess the cortical thickness. In this case, we can place the implant with high torque and we can load it immediately. In this case, even in dream, we will not place with high torque and we will never make immediate loading. What is the interest of ceramic implant? The friction coefficient are much lower. The rough surface are more aggressive on bone than polished surface. And this is one of the interests of the ceramic implants. We do bone graft and then we go to place implant. And we do two mistakes. First is believing that bone graft must be very dense. Secondly, placing implant with high torque. This is not the right way, because bone graft is not flexible and behaves as cortical bone. And then placing implant with compression will be fatal. We need to place this implant with a reduced torque. And we need to forget, definitely, immediate loading. When we place implant with high pressure, we will lose the bone. Placing implant in sinus will induce bone resorption, even after calvaria graft. Placing implant with high torque will kill totally the bone graft. Placing implant even after use of BMP2, and you see that at the crown delivery, means only after a few months, we lost almost the whole bone. This is a case of a late re-entry, making a bone augmentation with screw tenting and waiting 1 year. But why to wait 1 year? To achieve very dense bone? Maybe. But with a very dense bone, we know what will happen. The whole bone will resorb. Then all the pieces of the puzzle are in place. We publish already. And then what is the goal? The goal is to achieve the remodeling, the stability of the bone. And for this, we need osteogenesis and osteoclastogenesis. The first condition is to have enough antioxidant. Because with the antioxidant, we will get the immunity. And with the immunity, we will get the vessels. Simple. However, if we want to keep and to maintain the vessels, we need to avoid pressure and tension. If we want to increase the antioxidant, we know how. Vitamin D, immune supplementation, growth factors, autophagy. And if we want to have a low immune response, we need to forget, definitely, synthetic and bovine materials. Then we can propose solutions. The first is to improve the immunity in order to increase the antioxidant production and to shorten the inflammation. Vitamin D, obviously. Systematic testing and systematic supplementation. We can move to a strong immune supplementation. When the patient has a weak immunity, we can give him this kind of product, the immune force. We have a lot of product that can increase the production of antioxidants. We can use the autophagy. Ozumi got the Nobel Prize in 2016 with the autophagy. When the cells are infesting, they organize their own cleaning and eliminate all unwanted substance, including oxygen. It means that in fasting, we do a physiological detox, and we have enough evidence today that autophagy improves innate and adaptive immune response. Autophagy accelerates wound healing through angiogenesis. Then it's very simple how to induce autophagy by intermittent fasting. From 8 p.m. to noon, the minimum is 16 hours. Is it difficult? No. We just need to miss the breakfast. We propose today in our surgery the protocol of intermittent fasting, 5 days before and 5 days after. We can improve immunity with some antibiotics. We know since 40 years that macrolides, they have an immune function. And during the COVID, you know that we used largely azithromycin. At the beginning, I was thinking that it's a nonsense to use antibiotics for the COVID because it's a virus. But very shortly, I understood that if we use azithromycin, it's because it's the most powerful immunomodulatory antibiotic. And then I decided to use it immediately after the end of the lockdown. Unfortunately, we had a case immediately after the lockdown. May 2020, a patient came for bone augmentation in the mandible, and he was allergic to penicillin. We gave him spiramycin, and 6 days after, he came back with a monumental infection. Pus, swelling, pain. And then I advised the surgeon to do not open the abscess. I asked him to give just 2 days of azithromycin with 50,000 units of vitamin D. And the surprise was that the abscess was gone in only 2 days. The full recovery, we met it in 1 week. But the second surprise was the success of the bone augmentation. The first time in my life that I see a success in bone augmentation after infection. So now we can show more evidence about azithromycin. First, after the COVID, we started to get more papers showing that azithromycin inhibits oxidative stress. We know that azithromycin has some particulate pharmacokinetics. First, it has a specific action on the gum with a high concentration in all soft tissues. One dose is active for 1 week, and then the use is very easy. We give them only one single dose. And azithromycin today is better than amoxicillin in prophylaxis. So what are the protocols that we use since May 2020? Of course, we include the vitamin D and immune supplementation. For simple cases, we implant RGBR. We use one single dose the night before. Simple, and that's it. For the bone augmentation, we started to use 2 single doses, azithromycin the night before, amoxicillin 2 grams 1 hour before. But we started with this protocol. But today, we removed the amoxicillin. We don't need. We stay now with azithromycin 1 gram, 1 single dose, and that's it. However, we know that the gum is the main responsible of complication. And then when we have an inflammatory soft tissue or a thin biotype, then we give them weekly half a gram of azithromycin. And then the objective is to reduce the periodontium long-term inflammation. What gum loves most? Azithromycin powder on sticky bone. The gum really loves it. And how to use the azithromycin? Simply by going to the pharmacy and to buy a bottle of azithromycin for kids. It's powder. We can improve the immunity by using steroids. Usually we consider that cortisone is anti-inflammatory and then stop the inflammation. No, this is not the right mechanism. Cortisone shortens the inflammation period. And then 1 dose is enough. 1 hour pre-op, prednisolone 1 milligram per kilo, or dexamethasone 0.2 milligram per kilo. The second solution is to avoid any pressure on crestal bone. And then we need to over-drill the crest. The countersink is still mandatory since Bräunemark. And this space will avoid any bone resorption in the crestal zone. We can shorten the inflammation into the bone graft by using the sausage or the sticky bone. The objective is to fix the bone graft and to avoid any mobility. We can also consider that the PRF will help us into the stability, but also into the vascularization of the bone graft. And today, all the graft that most of the dentists are doing, they do it in a sticky bone form. We can use the plate, we can use the pump pack or the pump swing. This is how we manage one bone augmentation. We prepare one piece of bone graft and we put it in one shot. No granule, nothing, and we decide exactly the thickness of the bone graft. We can increase the blood supply with the PRF. Why? Why PRF will increase the blood supply? Because PRF today is a powerful antioxidant. Through this new publication, we can minimize the foreign body reaction. The third choice is to use the human bone, autogenous allograft dentin, because we will not have any inflammation. However, with the dentin, we will not meet any bone loss. With the allograft, we will meet volume loss. And this is why today, the best product that we have in our hand is a porcine xenograft, the Provo, because it has the advantage of both allograft and xenograft. No immune reaction and volume maintenance. So we can see now how the inflammation is short-term. After a full range implantation, we can see that after 4 days, there is no inflammation. Using the same protocol and controlling the patient after 3D, we see that there is still any inflammation. Look at the aspect of the gum after 5 days. Look at the aspect of the gum after only 6 days. It means that today we can control completely the time of the inflammation and to reduce it at less than 5 days. But if we have a powerful immunity, then we can move to the open wound strategy without fear of infection. We fill the socket with the sticky bone, and then we leave the site open. The gum will come naturally to close, but look at the amount of soft tissue, keratinized soft tissue, and look at the crest after only 3 months. In this case, it's impossible to close. We don't care, because PRF will help us with the immunity to achieve the best outcome. This case, in a sinus with a huge bone resorption, we can fill only with fibrin, leaving open, and then look at the new bone formation. We can place implant and leave the PRF on site, and then the open wound is the strategy in order to get a very nice keratinized tissue thickness. This is the same, making an augmentation with screw tunting, leaving open, and then look at the nature of the healing after only 1 week. We are sure that we will get a lot of keratinized tissue. Placing an implant and bone graft, we can cover only with fibrin. And then we can see how the fibrin is acting as a matrix, producing a new keratinized tissue. We can place the implant with a cyst without any bone material, just with sole PRF, and we can see how the implant is now covered by bone. Another topic is how to enhance the biotype without soft tissue management. We started many years ago, around 20 years, to make vestibuloplasty and to cover with PRF without any connective tissue graft. This is a vestibuloplasty with only PRF. And then we can see that we have a new vestibule after only 2 weeks. But we see that the papilla is growing. What is the conclusion? When we release the tension, we increase the blood supply, and then the gum will grow. We will say, if you give more food to the gingiva, it will become obese, like us if we eat too much food. Then we know that the soft tissue supplies the bone, but we would like to know how to supply the soft tissue, because we need to give to the soft tissue more blood supply. And this is how we design the soft tissue vascular overflow. We do a flap in order to make a separation between the soft tissue and the cortical bone. The cortical bone likes to make all the time suction of the blood supply. But if we put the trabecular bone, then this trabecular bone will supply the soft tissue, and this is how we will make the gum thickening. Then we can go to the clinic. We have 4 kinds of ridge, enough thickness, but for us, we need to make a separation between the cortical and the soft tissue. We don't need to cover with any collagen membrane. And then we can see what happens. We are getting a very nice soft tissue with a huge thickness and keratinization. I can show you some cases. After 6 months of this protocol, getting a very nice soft tissue. Soft tissue is thin, we will make the overgrafting, and then this is the new soft tissue, allowing to make a very nice prosthetic outcome. The soft tissue is very thin, it becomes very thick. And look at the rehabilitation. Thin becomes thick, thin becomes thick. Then the question is, what is the mechanism? The mechanism is the genetics. We know the power of genetics, and I want to show you one example I did in my pain experience. We made the cells addictive to the morphine, and then we provoked multiplication of the cells 200 generations. And 200 generation, mother, daughter, the cells are still addicted to morphine because the addiction is conserved in the genes during the 200 successive generations. This is the same for the gum. The gum has the keratinization capacity into the genes. We just need to wake up those genes. How? Increasing the blood supply. The keratinization will stay whatever happens over time. If we do not flap release, we will not meet thickening. We need to raise the flap and to make to put a layer of bone graft. When we place the implants, we need to take care of the axis. Do we need the digital planification, computerized guide? The reflection first is, should we worry about the anatomy? We see that we have a huge resorption. No, because the bone resorbs always after the pressure of the tongue. The bone loss is always buccal. And then we have always the posterior wall. And we will place the implant adjacent to the posterior wall, really adjacent and protected by the posterior wall. You see, when we do extraction, the posterior wall is still present, always conserved. This is the case in the X-rays, and look at the posterior wall. It means that then the placement is easy. Same case, look at this kind of jaws. Look at the posterior wall without any bone cut. So we know that we need to place the implant adjacent to the posterior wall, but we would like to decide the axis. And then we see that we have the very interesting anatomical information, the nasopalatal canal. The nasopalatal canal, if we place a pin into this canal, it gives us the perfect axis of the implant. Perfectly. When you place the pin into the canal, it's totally atraumatic, and we will use this axis to place the implants. You see, in different situations, we see that the canal will give us the perfect axis. This is the pin into the canal. We never cut, never, because we will lose the vertical dimension. And then, following the fast guide, we can see how the implants are parallel. Simply, equidistant from the pin into the canal. Look, doing this protocol, implant under the posterior wall with the same axis, this potter will design the bone papilla. This implant placement will design the bone papilla. The bone papilla is made by the posterior wall. Don't cut it, please. And following the fast guide, you will meet always the same axis. Also with ceramic implants. 6, 8, 10 implants, doesn't matter. Then we can talk about the osteoimmunology protocols. How do we set up this protocol? We do everything that biology likes, but too much. This is the over concept I designed a few years ago because we have a benchmark. We know that the tibia fracture heals in 4 weeks, and we can load it after 6 weeks. But when we do bone management in the oral cavity, it takes 3, 6, 9 months. This is not. It seems that we do something wrong. Let's go to see what we do today. We manage with the osteoimmunology protocol, with a non-inflammatory material. This is why today we select the pure gold material. And after 2 months and a half, we have the full healing. But it's still too much. Can we do it in less? Yes, in 2 months. Can we go to the 6 weeks? I believe, yes, we do it. It means that when we do this kind of protocol, we are just doing exactly what likes the biology. We can see the bone augmentation. We don't need to wait too much, no more than 2 months. In vertical augmentation, no more than 2 months. I show you a video to tell you that we don't lie. Vertical augmentation only after 7 weeks. And you understand that today, we are very confident into the osteoimmunology. The first conclusion is that the immunity is mandatory for integration, for bone maintenance, but it requires high level of antioxidant. The second conclusion is about ceramic implant. Obviously, it's the best for osteoimmunology because there is no immune reaction, no corrosion, no oxidation, less traumatic, and we have the best attachment to soft tissue. Conclusion 3, we know how we lose the bone because of the immune deficiency induced by the oxidative stress. And then we can say peri-implantitis is an immune disease. This is the answer that we wait since 20 years. Why peri-implantitis? Because of the immune disease. But how occurs this immune disease? Because we forgot to remove the pressure. We forgot to remove the tension. And then we will say, does peri-implantitis are caused by the surgeon? The hand of the surgeon is one of the main responsible of the peri-implantitis because we have a chronic inflammation. We know the situation. Diabetics, obese, smokers, deficiency in vitamin D, chronic inflammatory disease, bonding material. And we have the last origin, which is the soft tissue incompetency. What does it mean? The symbiotype. Because the symbiotype is incompetent to avoid bacterial penetration into the periodontium. I found this paper showing how many people have a symbiotype. 1/4 of men, half of women. It means that 1/3 of adults are naturally candidates to peri-implantitis because of their soft tissue. And then these people, we need absolutely mandatory to manage, to reinforce the soft tissue around the implant when we have a symbiotype. Soft tissue thickness has influence on severity of problems. Look at these two situations. Implant 1, the soft tissue is thinner, and we see that implant 1 has more bone loss. How to treat the peri-implantitis? Today, simply, we need to manage the periodontium inflammation. How? First is to improve the patient immunity. You cannot start to treat the peri-implantitis without immune supplementation. We need to increase the soft tissue thickness, otherwise we will meet again peri-implantitis. We need to use non-inflammatory biomaterials. Again, I will tell you, please forget definitely synthetic and bovine. We need to use local and general azithromycin because it helps into the immune reaction. And we need to make an over-release of the flap in order to remove any tension. Osteoimmunology is the key of long-term stability. We did everything in this patient. No pressure, no tension, control biology, overgrafting, and then we got a very nice soft tissue. We will say it's an effective periodontium. And what happens after 15 years? We will say nothing. Why? There is no reason to lose bone because we did a perfect surgery. Even after 10 years, there is no reason to lose any bone. Even after 13 years, there is no reason to lose anything. My friends, you understand that osteoimmunology is today the most important topic. And this is why we invite you to join us at the SciFac in June. We will have a lot of speakers. French and international, and we organize a crazy week with live surgery courses. Thank you, my friends, and you can write me if you have any issue to my email.